Supraclavicular brachial plexus block is indicated for surgery distal to mid-humerus, elbow, forearm, wrist and hand. This patient is posted for right hand surgery. IV access was achieved and standard minimal monitoring was applied. Patient was given supine position with head turned to the contralateral side. Position the head at the end of the pillow to have enough space to scan. Using all aseptic precautions, anterolateral part of the neck is painted, prepared and draped. Here for the block, I have taken 10 ml of 0.5% bupivacaine plus 10 ml of 2% plain lignocaine. I am using a 50 mm 22 gauge block needle with 10 cm extension for injection. High frequency linear probe is ideal for scanning small superficial structures. The probe is prepared by applying a linear layer of KY jelly and draping the probe with a sterile short sheet and a transparent dressing. Mild sedation was given with 1.5 mg IV midazolam and 50 micrograms of IV fentanyl. For the beginners, the ultrasound probe can be first placed in the neck at the level of cricoid. Locate the carotid artery, move slightly laterally and then downwards and then gradually tilt the probe caudally, aiming at the ipsilateral thoracic cavity. In the ultrasound image, you can see the carotid artery. As you move laterally and downwards, you can identify the anterior and the middle scalene muscles with the three trunks of brachial plexus between them. This is the traffic signal appearance of the interscalene block. As you tilt the probe caudally, we can see the subclavian artery over the first rib with brachial plexus lateral to it. Alternatively, you can directly place the linear probe in the supraclavicular fossa in transverse orientation parallel to the clavicle. In the ultrasound image, we can visualize the pulsatile subclavian artery and lateral to it the nerve cluster of the brachial plexus. A color Doppler, in addition to sonographic examination, helps us detect any aberrant vasculature. Pulsatile subclavian artery can be seen. Presence of arterial and venous branches adjacent to or running through the brachial plexus in supraclavicular and interscalene region is common. Small, non-compressible arteries may appear near the nerve bundles. Color Doppler in the needle path and site of local anesthetic placement will prevent any inadvertent vascular punctures. Using a 26 gauge short length needle, about half ml of 2% lignocaine is given for local anesthesia. The needle can be seen in the subcutaneous tissue. Inject the local along the needle track and avoid deep injections. Avoid piercing the underlying fascia, especially if you are going to be using a peripheral nerve stimulator. The block needle is introduced about 1 cm away from the probe from lateral to medial side. Needle is introduced almost flat and completely in plane to the ultrasound probe for better visualization of its entire length. Always keep the needle's tip under vision in the ultrasound image. Once the needle tip has punctured the fascia, inject about 2 ml of the local anesthetic drug and check for its spread. This is the first injection, which is superolateral to the plexus. Once you are happy with the spread of the drug, inject around 10 ml of local anesthetic drug over here. Inject in small aliquots of 2 ml each. Aspirate before each injection to confirm negative aspiration of blood or any other body fluid. Do not inject if there is any resistance or pain on injection, as you would be too close to the nerve or even maybe intraneural. The second injection is in the pocket between the subclavian artery, brachial plexus and the first rib. Inject another 10 ml of local anesthetic drug here and you will see the brachial plexus getting lifted above the first rib. The drug surrounding the plexus gives a donut-like image. Now gently withdraw the needle. Gently massage the injection site for a good spread of the drug around the plexus. Check for loss of sensation and motor power after 15 to 20 minutes. This patient underwent close reduction and K-wiring of the metacarpal and the distal phalanx of the little finger as well as tendon repair with tourniquet over the arm for 2.5 hours. Patient was comfortable with IV sedation using IV 2 mg midazolam and dexmedetomidine infusion along with supraclavicular brachial plexus block. Thank you.